Succes i veterinær praksis, podcast nummer 113. Dyrlæge Søren Pejstrup her. Velkommen til. Hvis du synes, det her med thoraxrøntgen kan være lidt svært, så skal du lytte med i dag, for du får faktisk, hvad der svarer til et lille minikursus helt gratis i det her med thoraxrøntgen. Udfordringen er selvfølgelig, at det er dig selv, der skal sætte dig ned og lære det her. Vi kan servere viden for dig, men hvis ikke du får arbejdet det ind under fingrene, eller huden, eller øjenlågene, så kommer det ikke til at rykke noget for dig. I dagens podcast, der går Allison og jeg igennem det her med thoraxrøntgen og de forskellige mønstre, vi kan se i lungerne, når der er patologiske forandringer. Det er selvfølgelig lidt svært, når det her er en podcast uden billeder, men når du har hørt den her podcast, så kan du gå over på hjemmesiden og finde links til cases, som kan lære dig noget mere om det her. Det er nemlig sådan, at Allison har en hjemmeside, hvor hun ofte deler nogle interessante billeddiagnostiske cases, som ofte er det røntgenbilleder, og hun har bygget det sådan op, at man ikke får svaret direkte. Der er en beskrivelse af casen, og vi kan se røntgenbillederne fra forskellige vinkler, og så kan du komme med dit bud på, hvad det er, og helt uden at der er nogen, der peger fingre, så kan du prøve at gætte på, hvad du kan se, og hvilke mønstre du kan se, og så kan du folde facit ud bagefter. Det er en rigtig interessant måde at lære på, og hvis du gerne vil være bedre til det her med thorax cases eller thorax røntgen, så er det her en serveret for dig, så nemt som det nu bliver. Udfordringen bliver som sagt bare, at du skal gøre arbejdet, du skal gå over på hjemmesiden og finde de her links, og du skal kigge på røntgenbillederne, og du skal måske prøve at se, om du kan gætte det, og rent faktisk skrive et svar ned til dig selv, inden at du får dig facit ud. Det kan være meget godt at lytte til de her podcast, men hvis ikke du tager handling på det, så bliver det bare underholdning, og det var måske ikke helt det, vi skulle bruge tiden på, men nærmere det rent faktisk også flytter os fagligt. Men det er selvfølgelig helt op til dig selv. Du har i hvert fald muligheden i dag. Linksene og noter til det, vi snakker om i dag, det er på hjemmesiden på SIVP.dk/113, altså SIVP.dk/113. Og når du nu er over på hjemmesiden, så kan du måske tænke på, om du har lyst til at være med på nyhedsbrevet for dyrlæger. Du kan tilmelde dig nemlig over på hjemmesiden, og jeg gør meget ud af, at jeg ikke spammer på det nyhedsbrev eller på den nyhedsmail. Jeg gør meget ud af at prøve at sende noget faglig relevant viden, links til fornuftige podcast, PDF-filer med downloads og checklister og meget andet. Så der er rigtig meget fagligt indhold i den e-mail. Jeg snakker selvfølgelig også lidt om de kurser, som jeg har over på hjemmesiden, og som jeg prøver at sælge adgang til. Og hvis det viser sig, at det nyhedsbrev ikke er noget for dig, så kan du fremmelde dig med et enkelt klik. Tænk over, om du har lyst til at være med. Du kan tilmelde dig i bunden over på artiklen på hjemmesiden på SIVP.dk/113. Og så over til interviewet med Allison. Hi Allison, and welcome to the podcast.
Thank you very much. Thank you for having me.
I know you a little bit, mostly from your blog or your website, but you have your hands in pretty much everything. It seems like image related. So, can you maybe give us a Cliff's Notes introduction to who you are?
Yes, certainly. I am an associate professor at the University of California in Davis, and I've been here for about 12 years. And I did my residency at the University of Pennsylvania in diagnostic imaging. My main jobs here are to provide clinical support in the clinic, and my research also covers a lot of oncologic imaging and a lot in CT and MRI with vascular imaging. And then, as you mentioned, I have a blog that I like to create content for that is continuing education in imaging. That's available for anyone who's interested in getting small doses of case-based learning on a regular basis. So that's available. And I'm also active both in the American College of Veterinary Radiology and the European College of Veterinary Diagnostic Imaging. So I do like to keep abreast of what's happening in our field. It's really exciting at the moment with all of our new developments, technologies, and capabilities. So I do try to help out where I can and contribute to the profession and try to spread that out to the rest of the veterinary community.
And maybe we should have the URL for your website as well.
Sure, it is veterinaryradiology.net, and that's all one word.
Yeah, and you have a ton of excellent information on that site. I can say I really enjoy the cases, and that's what I mostly look at. And it's and I feel that's it's very good way to get into, especially radiology. We only have direct radiology. Direct radiographs in the clinic where I work, so we don't have CTs and MRI, but we do look at radiographs pretty much every day. And your cases it's not more that I can handle. It's not 10 pages of text I have to go through. It's one case and I get something out of it, and I can get on with my day. And that's one of the reasons why I like your website. And I hope to bring some of the knowledge about your website out also in this interview.
Yeah, that's the idea behind it. It's just a little bit of extra knowledge that you can take on your own time. And I try to provide cases that are interesting and have something educational in the content. And I think the key point is that all of the cases are known. So we have answers to them. We know what the diagnosis is. And that's really where the learning can occur. As I know in the clinic, it can be difficult when you don't get answers on some of your cases because of financial constraints or lack of ability to perform certain tests or procedures. And so these cases that come through our hospital, I think, are super valuable in terms of their learning content when we find out the answers.
Yeah. And I know it's going to be a bit of a challenge, maybe, to talk about images in an audio-only podcast. So maybe we should afterwards find a couple of thoracic cases that I could link to, and people can have a look at their own time as well. Maybe we should see how far we can get without any images to look at. My thought that we could maybe start off with the 4 image patterns. I don't know if we are supposed to use them anymore, but I was taught that back 10, 11 years ago when I was at university, that the way into a thoracic radiograph was to find out what image or image pattern, thoracic pattern we had. Is that still the case?
It is. It's a starting point for us to be able to try and figure out what the underlying pathology is in the lung. So we're trying to use those patterns to decide where the pathology is originating from, whether it's the airways or the alveoli or the interstitial tissue. And so that's really the basis of why we try to figure out what those patterns actually represent on the radiographs.
And is that what you start off with when you see a case, a thoracic case?
Yeah, I think if you just think about the very basic thing to start off with, I always think about, is it normal or abnormal? And so that's the first thing to try and decide for yourself. And I always tell my students to use a systematic approach for that at first, to try and look at all of the different components of a thoracic radiograph, all of the different organs, the lungs, the heart, the mediastinum, the pleural space, and try to decide, which one is abnormal. And if it is the lungs, then you definitely need to start thinking about what pattern it is that you see. Where is there extra opacity or not as much? And do you think it fits into one of those categories that we usually start with? Mm-hmm.
And that's maybe where the challenge comes in, is actually having that systematic approach, because my brain tends to go straight for finding some kind of answer and looking just scattered around in the image to see if I can find any clue, and then I end up by finding nothing, actually.
Yeah, it is a challenge, and it's also a starting point, because I think if you go through that pattern until you're really confident with it, eventually you start to have more of a global recognition of whether the radiograph is normal or abnormal. And so it's okay to go straight to the abnormality once you've gotten to a certain level of experience. And then you just check the other things later once you've had to think about what you think the abnormality is. But you do need to just remember to check that there's nothing else in the radiograph that will help you add to your clues that are present in the image.
Yeah. So can you give us maybe an overview of what the patterns are?
Yeah, so I think the maybe most striking one, and the one people tend to start with, is the alveolar pattern, which really represents a filling up of the air spaces within the lung with fluid. Whether that's inflammatory or edema, once those air sacules and alveoli become filled with fluid, they become a pretty uniform soft tissue opacity. And so any sort of area that looks like a very uniform field of sort of a soft tissue light gray is something that we would call an alveolar pattern. And one of the things that people recognize or look for as a sign that it's an alveolar pattern is an air bronchogram. And I think most people have looked for those. And the pattern there is that you have an air-filled bronchus in the middle of that very uniform soft tissue opacity portion of the lung. And it's just another clue that there is extra fluid in that portion of the lung. So the bronchus itself isn't filled with fluid, but all of the air spaces have. So those are the main, signs that you would look for in terms of an alveolar pattern.
So, and you wouldn't be able to see the vessels here because they are also fluid.
Correct. So the vessels are within that lung as well, and so once they get surrounded by fluid-filled alveoli, then you can't see them anymore. So, right, that a lack of visibility of the vessels also helps you understand that there's an alveolar pattern.
Yeah. Because sometimes I feel like the patterns overlap a little bit, and I'm looking for clues as what box to put it into.
It's true, and if you think about the pathophysiology, the interstitial pattern, which is where there's fluid in the interstitial spaces between the alveoli and kind of gives you a hazy pattern throughout the lung, or more soft tissue, but you can still see that it's air-filled. There's actually a continuum between the interstitial and the alveolar pattern. Think about a dog that's got pulmonary edema from heart failure. It's going to start as an interstitial pattern with fluid filling up the interstitial spaces. And then as that becomes more and more, it breaks down those barriers and starts to spill into the alveoli. So there's actually a gradient between interstitial and alveolar. Yeah. So sometimes it's not possible to put it in one box, and you can say it's somewhere in the middle.
Yeah. And is there any clues on how to see the difference if the difference is obvious enough?
Yeah, I think the vessels are a good way to try and differentiate. If you think there's too much opacity in the lung, but you can still see the vessels, then I would probably go with an interstitial pattern. Whereas if you can't see the vessels and you're starting to see our bronchograms, then I would classify that as an alveolar pattern.
Yeah. So that's two types of patterns.
Yeah.
And there's two more?
We usually go with a nodular pattern. It's kind of a subset of the interstitial pattern. And I usually stick with those three categories. So okay. I will call a nodular pattern. It's technically interstitial, but I think you can just say nodular. But that's actually solid tissue forming within the lungs. So we won't subdivide that too much further. But we can call the nodular pattern something that you'd see, for example, with metastatic disease. So if you have nodules of tissue forming from disseminated neoplasia, so the cancer cells have traveled through the vasculature from some other part of the body and lodged in the small vessels and interstitium of the lung, and they start to grow there. So you get these solid nodules causing variably sized multiple nodules throughout the lung, which are usually fairly easy to detect, but it does depend a little bit on their size. So the bigger they are, the easier they are to see. And so my clue for that is to try and say, are there one or are there more than one? And if there's more than one, I'm more convinced that it's actually a nodular or metastatic type pattern. So looking for the number of nodules you can see, I think, is helpful. Yeah. You can also sometimes see a solitary nodule, a solitary large one, and that could be as small as a very small type of nodule, a couple of centimeters, all the way up to a big mass. And so depending on the size, you'll be thinking about different types of differential diagnoses, but the characteristics are the same. They're solid. There's usually no airway in it, right? Like we see like an alveolar pattern, and it has distinct round borders. So it's different from the alveolar pattern in that way that you can see all the way around the border, and it has a particular shape, not just conforming to the lung lobe.
And you say, of course, this also depends on the size of the nodule. How small a nodule would you say that we can see? Maybe a vet like me and a vet like you. How small are we able to find them?
Yeah, technically we're only able to see about a centimeter or two on a radiograph. And if you CT the dog, you'll see much smaller nodules, and they'll be much more apparent at that size. So we have to realize that radiographs are a little bit limited in that way in terms of what we can distinguish, but still a very, very useful tool.
Yeah, so some earlier disease we will not always be able to pick up on a standard radiograph. No.
Correct. And then the final pattern we have is bronchial, which is associated with primary airway disease. And so in various types of inflammatory disease, whether it's infectious or non-infectious, the airways are the primary source of disorders. So in that case, the bronchial walls become very thick, and we'll start to see really, really distinct bronchial walls all the way to the periphery of the lungs. Normally, they're thicker at the hilus level and thinner towards the periphery, and you can't really see them beyond 1 or 2 branches usually in a normal dog. They're made of cartilage, but they're quite thin, so it's difficult to pick up. But as they become thickened with inflammatory tissue, granulomatous tissue, thickened mucosa, mucus, then you start to be able to see those walls much more distinctly and also much further in the periphery of the lung. And that gives you a whole different set of diseases to start thinking about for the animal, whether it's something that's infectious like kennel cough, or something that's more of an autoimmune type disease like asthma in cats. Those are the types of things you start to think about if you see a primarily airway associated pattern.
Yeah. And you also talk about that they will tend to be in the periphery later, at the later stages. So, yeah. Yeah.
So if we have a greater degree of thickening of those bronchi, you'll be able to see them farther out in the periphery. So the more severe the disease, the more thick they'll be out in the periphery where you don't usually see them.
Yeah. So then we if we go back to the cardiogenic edema, and then this is maybe in the periphery, is there any clues to the disease process as to where in the lung fields we see the changes?
Yeah, the distribution is a really important part of how you start to think about where the pathophysiology is originating and which pattern you're seeing. And with the example of cardiogenic edema, in dogs, we usually start at the hilus of the lungs, and it usually starts to originate there and then expand out peripherally. And so if it is concentrated in that particular area and you're seeing an interstitial or alveolar pattern there, and the heart is big, then that would definitely be the top of your list. For another example would be a non-cardiogenic pulmonary edema, so something like animals that are almost choked with their collars or near drowning episodes, they get a pulmonary edema that's very caudodorsal but away from the heart. So it's concentrated in the caudal lung lobes, but not in the hilus area near the heart, and it's very evenly distributed. So that would point you more towards a non-cardiac cause of that pulmonary edema.
Yeah. How about here in Denmark? We don't have the heartworm that you struggle with in the US. We struggle a little bit with the angiostrongylus, and we call that one a heartworm just to confuse everybody. And you can sometimes see both of them in radiographs as well, just to maybe to take cases that we see from time to time. Where would we see a case like that, and where in the lung patterns would we see a case like this?
Well, for heartworm, you would see enlargement of the pulmonary arteries. So they become enlarged and tortuous because of the arteritis caused by the heartworms. It's not worms themselves in the arteries, although they are sort of in the base of the arteries, but they cause thrombosis of those arteries, and they cause inflammation of the walls. So we get these very enlarged, thrombosed, tortuous arteries that end abruptly. So instead of seeing a nice tapering point and some branches, you'll see just a blunt cutoff of that artery. And they're very, very obvious on the image. We'll also see right heart enlargement as the worms cause obstruction of the pulmonary arteries. The right heart starts to hypertrophy and work harder against that. So that's another feature of heartworm. They will also get some nodular change because the inflammation in the vessels also affects the lungs near the vessels. So we will see some nodules and interstitial to alveolar pattern in a patchy sort of way that just results from all of that inflammation going on in the arteries.
So we have actually clues outside the lungs as well in the radiographs here as well.
Yes, absolutely.
Yeah. Maybe another case, or maybe a thing that we here in Denmark actually we see from time to time is these brachiocephalic dogs. The French bulldog is getting very popular here in Denmark, and they sometimes get changes in the lungs as well, don't they?
Yeah, brachiocephalic dogs have a lot of characteristic signs, both in the upper airway on radiographs and in the thorax. The first thing I always think when I look at those dogs is it's very crowded in there. So the heart always looks big in relation to the volume of the thorax because their vertebrae are so short. So there's always vertebral anomalies. It's sort of normal for the breed. The heart always looks big, although if you look at the individual chambers, there's not always cardiac enlargement. And then the volume is small. So in those guys, I think it's key to look both at the lateral radiograph and the DV or BD, and you'll see in the more DV direction that there's actually more lung than there appears on the lateral, just because their shape makes the lateral, they're sort of shorter dimension, so it makes it look more crowded in there than it really is. So I definitely look at two views on those. They always have a very wide mediastinum because of fat accumulation in there. So that also makes the whole thorax look opaque when you're looking from the lateral direction. So again, your DV or BD is going to help you decide that no, there probably isn't really lung disease in the cranial ventral lungs. It's probably just fat in the mediastinum. And then if you take a neck radiograph, a lot of these guys have upper airway issues that they present for to your clinic. A nice straight lateral neck radiograph can be helpful to look for tracheal collapse. It's pretty common in those breeds. Tracheal hypoplasia, and also the upper airway signs, which are a very thick, soft palate. So that's very common in those. And also pharyngeal collapse. One of my colleagues, Rachel Pollard here at UC Davis, just published a paper documenting that the brachiocephalic breeds almost most of them have pharyngeal collapse during normal respiration. So that whole formation causes collapse of the pharynx during inspiration and expiration. That sort of adds to that sound and that stutter that you hear when they're breathing.
Yeah, so it's not always the nose.
No, it's not always the nose. The nose causes a whole chain of events right down to the base of the lungs. So,
right, and maybe just one more case, because I had just had it today. Actually, it's a kitten with FIP, and the abdomen looked okay to me at the radiographs, but the lung patterns was moved up to the upper caudal part of the thorax, and it was only like 30% left, and the complete ventral part of the thorax was completely opaque, and we couldn't see the heart shadow, and it was just gray. But that's not a lung pattern per se, is it?
Right. So in FIP, there are a couple of different presentations, and I think the one that you're probably describing is pleural effusion, where they have a collection of fluid between the thoracic wall and the lungs themselves. And this can affect either just the thorax or both the thorax and the abdomen. So you can see either one of those with FIP, and it's inflammatory granulomatous type disease. The other presentation I've seen is with multiple very tiny nodules all throughout the lungs, so little granulomas that have deposited in the interstitial tissue in response to the disease. So I guess that's the difference between the wet and the dry FIP that you'll hear talked about. Mm-hmm. But either way, it can present in a few different formats.
Yeah, but the lungs or the rest of the lung pattern looked fairly normal, apart from it being very small.
Yeah, they just collapse in response to that increased volume in the pleural space. So they kind of float up towards the caudodorsal part of the thorax and contract away from the chest wall. So you get that very uniform soft tissue opacity in the ventral thorax because of the pleural effusion.
Yeah. So this was just a couple of cases with no order to them other than it's cases I see from time to time and I'd like to ask you about. But maybe you could tell us what kind of things you see on radiographs that we could maybe do better, because I'm guessing that you look at quite a lot of cases, and maybe you from time to time see things that could have been done better, or things we could do with the thoracic radiographs that can make your interpretation easier or maybe more precise.
Yeah, I think the technique in thoracic radiographs makes a big difference in terms of the amount of information that you can get out of them, plus your confidence in interpreting them. So the better quality you start off with, the more you're going to be able to do with the images, and then the more you're going to be able to do for the animal. So a few things for technique are, first of all, to make sure that your technique chart is set up correctly. And this is something that your vendor should be able to help you with your x-ray machine, and your technicians should keep on top of, so that you're happy with the quality. And then once it's standardized, then it's very easy to reproduce good quality radiographs. The second thing I think is important is symmetry. So if you have your dogs or cats positioned in symmetric ways so that they're not off angle anyway, or they're not rotated on the DV or the VD, if the neck is straight, these things all make a difference in terms of how much of the thorax you can see and how you can compare from side to side. Because a lot of what we do is look at one side and the other and say, oh yeah, we do think this side is abnormal compared to the other one. Or is the disease unilateral or bilateral? And if you can't see both sides equally, it becomes a lot more difficult, I think, to judge that. So I think symmetry is important as well. And then the third thing I might mention is thinking about the position you put the animals in. And for example, the case you mentioned you had today of the FIP, in that case, if your normal radiograph is a lateral and or two laterals and a DV, you might think about doing a ventrodorsal or a VD instead, because then the pleural fluid is going to collect underneath the heart, and you'll be able to see the heart much better on that view. So there's different positions that you can think about in terms of working with the pathology or the conformation of the animal to try and get the most information out of your images.
So if you could wish for something, would you always wish for 4 images, 2 laterals and a DV and a VD, or can we get by with just 2?
I think a happy medium is 3.
Yeah.
I would say that between the VD and the DV, if you get one of those of good quality, it's fine. If you have an animal with pleural effusion, you'll probably need to do both, or choose the VD. And then for the laterals, I know a lot of clinics still do just a single lateral projection, but if you think about the way the animal is made, when the animal's lying on the table, that down lung, the lung on the table side is collapsed because of the weight of the rest of the animal lying on it. And that decreases the contrast between any nodules in the lungs or any alveolar pattern, because that whole lung is going to look more opaque with that increased pressure on it. It doesn't inflate as well. So taking both laterals allows you to inflate both lungs, the top lung, the up lung, and get the best view of both of them. And I do think you'll miss things if you'll only ever take one lateral radiograph, especially things in, for example, in the dependent part of the right middle lung lobe. When you look at that on the DV or the VD, it's actually positioned underneath the spine. So you won't necessarily see it on the VD if you saw it on the lateral, or if you didn't see it on the lateral. So I do think that 2 lateral radiographs and 1 either VD or VD would be the optimal way to go.
I sometimes also with my colleagues discuss whether we have a nodule or not when we look at maybe a vessel end on, and we can't find it on the other side. So I think this might be something that I've thought of myself, but if I can't find it in both lateral radiographs, I'm a bit hesitant to make any conclusions.
That's true, but it can fool you a little bit with the 2 laterals, because it can get hidden on the other one if the lung is opaque enough around that nodule. Another thing you can try, which can be helpful, is to take the same lateral, but move your center of the beam, either cranial or caudal, to that nodule. And that because the beam is angled, right, it starts from a certain point and it fans out, you'll get a different perspective on that nodule if you centered the radiograph in a different position. So sometimes that can help you decide whether it is actually part of a rib, or if it moves away from the rib on the second radiograph, or if it looks not completely round anymore once you've moved it away for a different angle. So that's another trick you can try.
Yeah, so the shadow will actually move like the shadow in a car when you're driving past lights outside.
Exactly.
Yes. Here in Denmark, we are allowed to be in the room when we take the radiographs. I know you're not allowed everywhere in the world, so you would have to sedate some of these animals. Does it make a huge difference for you? Should I start sedating my patients, or should people stop?
Yeah, well, there's 2 components to that question. And the first one is radiation safety, which I think that if you're properly trained in radiation safety and realize that distance and shielding are your main defenses against scatter radiation, and your technique chart is optimized, and you've taken the proper precautions, it's okay to be in the same room with the animal, as long as you've taken all of that into account. But I don't think you should probably manually hold for every radiograph, because that will result in significant dose to your personnel. Once you've taken that into account, the second argument for sedation is being able to get those high quality radiographs. So being able to position the animals optimally without struggling, without stress on the animal side. It's more efficient probably for the technicians as well. It takes less time to take sedated radiographs than it does unsedated. And really the quality suffers, especially if you're doing things like specialized orthopedic radiographs that require multiple views of a limb that might be painful. Those type of things really are smoothed out by using sedation on your patients.
I've tried one too many times to send out radiographs to the specialists that we use and colleagues, and they come back with it should be more symmetrical, it should be more straight, and so I just stopped altogether by trying to make radiographs of the spine and knees and hips without sedation. So that I had to learn the hard way, but we all learn, I think. But the third case is I'm a bit more hesitant to just sedate them, and we've been a little more cautious with the airways and giving them oxygen, and it takes a little more effort.
Absolutely, and it depends, of course, on patient safety. So it's always a balance between patient safety and operator safety and making the test worthwhile, getting the information that you want, being able to get enough imaging information with that patient positioned or cooperating the way you need it to.
Yeah. So I'm reaching the end here of my questions on the list here. Is there anything important that you think we should also know? Do you have anything else?
I think the key to improving your imaging skills is to practice. So I would take the opportunities to make little changes. I know change is always difficult to implement and communicate in a busy practice, but if you decide that you're going to improve your positioning or maybe sedate your spines for radiographs or look at a case every week online, all of these little things will start to make a difference in improving your skills. And I think imaging is something that everybody likes. They know it's useful. They know that they can translate that information into better patient care. And so it's both an enjoyable and a worthwhile pursuit, I think, to improve your imaging capabilities in your practice. And it just leads to better medicine, I think. The more you can learn, the more you can actually do for your patients.
Yeah. And there's, of course, a whole lot more we can dive into with these thorax cases, and we haven't even discussed the clinical side of things and all the other organs in the thorax and what you can get from looking at the abdomen as well and everything else. So just to make clear that we know we haven't done the complete justice of thoracic radiographs just by talking here for 35 minutes, but it's good to have a starting point, I guess.
Yeah, absolutely. There's a lot of different topics that you could definitely go into, but I think we covered some of the basics and some of the things that maybe are questions for people working in private practice, where the small things can really make a difference to improving your imaging skills.
Yeah. So I'm guessing we're going to find a couple of good cases from your website, and I'm going to link to those from to the show notes to this episode. But I can't obviously write what the answers are. That will take the fun out of the cases, because you have made it so on your website that the answer is hidden. So we have to commit to some kind of answer before we get it. So and that is a very good thing for the learning as well. So maybe we should just link to a couple of cases without telling too much about them, and people can go to your website and try to learn more.
Sure, I'll find a couple of cases in the realm of what we've talked about today. And you're right that having to actually commit yourself to an answer is a much better learning experience than just looking at what it was. Yeah. So I do encourage people to write it down or say it aloud before they actually go and look and see what the case was.
And I will encourage everybody listening to sign up for your email list as well, because you're very good at sending out these interesting cases, and it's what I've seen is it's mostly, or is it just, it's only radiographs, right?
It's mostly radiographs, and that's a little bit of a software limitation. Mm-hmm. The software doesn't do videos and stacks of CT images very well. But I think radiographs are a good place to start for most people, because you can cover the entire body, and I try to provide a variety of cases that are of interest to most people. Yeah.
So thank you very much. Maybe is there anything else, or is there anywhere else that is good to get in contact with you, or is the website is the main spot?
Yep, the website holds all of the cases, and everybody's free to use those anytime. We also post the same cases on Facebook and Twitter if you are consuming your news in those arenas. So you can always find us on there as well. And I just encourage everyone to keep learning and enjoy the process. And it's always fun to find something that you can improve on and make a real difference in your practice and in different animals' lives.
Yeah. Thank you very much, Allison, for being here and for your time.
Thank you very much. It was a pleasure.
Husk at kigge over på hjemmesiden på SIVP.dk/113 og find de her links til de her kliniske cases, som du kan gætte med på og forhåbentlig blive klogere af. Der er også links og noter til det, vi har snakket om, og så er der links til de andre steder, du kan finde Allison. SIVP.dk/113. Vi høres ved igen på søndag. Tak for i dag.